recording.
I'm very glad to be here by video. I'm sorry I wasn't able, because of a different commitment, to be here in person. I've spoken with Peter Sands and others who asked me to just offer a few broad remarks about economics and global health. I'm very glad this symposium is taking place because it seems to me that economic analysis has an enormous amount to contribute to the whole field of global health. It's hard to imagine an area of research, an area of knowledge, an area of human service where the stakes are larger than in global health, where the issues affect literally the difference between life and death for millions, if not tens of millions, of people each year. Confronting a moral issue of this magnitude, there are two perspectives about the role of economics. There are many who feel that economic analysis, in a sense, trivializes a profound moral issue. There are many who feel that trading off one disease against another, trading off availability of one kind of treatment against another kind of treatment, thinking in terms of economics, in terms of money, or in terms of prices, is somehow wrong, that the issue is best framed in absolute moral commitments. And there's certainly a role for approaches of that kind. The Alma Ata Declaration 40 years ago was surely a positive spur to the development of better healthcare access and, as a consequence, better healthcare outcomes around the world. And certainly the Millennium Development Goals and their successors, the Sustainable Development Goals, serve very important objectives. But I have to say, and this reflects the biases of an ex-Treasury Secretary and of a professor of economics, that it has always seemed to me that the more important an issue is morally, the more important it is that economic analysis with respect to that issue be done correctly as a moral imperative. The perspective of an economist is that resources are inherently limited. As someone once said to me, perhaps overstating matters, "Larry, you can do anything, but you can't do everything." I doubt I could do anything. There's plenty of things I could not do. But the comment made a powerful point that whatever the level of generosity of aid donors, whatever the availability of philanthropic resources, with whatever degree of success we have with respect to persuading governments that they need to devote more to healthcare priorities, there will never be enough resources to do everything that would have positive value, or even to do everything that seems like it's very important. And therefore, choices have to be made. And it's hard to argue that it isn't better for those choices to be made thoughtfully on the basis of rational analysis and data, rather than on the basis of reflex or on the basis of emotional instinct. And that's why I believe that economic analysis has so important a contribution to make to your topic today. What are some of the priorities? I think a first priority has to be economic analysis that demonstrates the magnitude of the burden of global disease on economic performance around the world, and demonstrates the high rate of return available on well-designed interventions. We tried to provide some of that analysis in the context of the Global Health 2035 Lancet Commission report that I was privileged to chair a few years ago, along with Dean Jameson. We made the case that the economic value of improvements in health was substantial relative to the overall economic growth of countries, and made the case that the right kinds of investments could have payoff ratios over time of 9-to-1 or even 20-to-1. But that analysis has not yet been done on a country-by-country basis. It has not been done for all interventions. There's much that remains to be done simply in making the case for the enormously positive value of appropriate health investments. A second priority is economic analysis for resource allocation choices. Which diseases yield themselves to the most effective, the most cost-effective treatments? In what areas is it most likely that a research dollar allocated will, down the road, translate into meaningful reductions in pain and suffering, or extensions in life expectancy? What are the benefits to investments of different sorts? These are profoundly important questions, and something I am struck by, both as I look at the literature and as I find myself in conversation with advocates for different kinds of investment, is that while we now have common metrics for evaluating the global burden of disease and evaluating what the total suffering, total loss of life is from a variety of conditions on a comparable basis, when it comes to advocating payoff for investment, every cause does it in its own way. And so we don't really have a basis for strategic choice. And my hope would be that over time, research can put investments in different spheres on a comparable basis, or at least find ways of making them available for comparison so that resources can be allocated more rationally. Some of this goes to one type of treatment versus another. Some of this goes to questions that will be much harder to answer, like the respective value of increased investments in clinical care and increased investments in new research. I'll never forget Barry Bloom, the then dean of the Harvard School of Public Health, asking me when I was president of Harvard, which would you prefer to have invested in, Larry? Scholarships for iron lungs in the 1950s, or the research of Salk and Sabin on the polio vaccine? It was a powerful reminder that sometimes more indirect approaches through research to reducing pain and suffering are the most availing ones. A third vital area is the examination of the systemic incentive effects of various kinds of support. Here I am always struck in the international community and in the assistance community that issues of fungibility do not receive the attention that they deserve. It's all very well to say that it's a good idea to give the government of country X an extra $100 million to support the strengthening of its healthcare sector. But one has to ask the question, does one's gift of $100 million translate into an extra $100 million spent on healthcare, or does it translate into the government reducing its commitment to health by some amount, perhaps even $100 million, and reallocating the resources to a different use? There's growing evidence with respect to assistance to education and assistance even to health care, that the domestic provision of resources to governments leads more to their reallocating their own efforts than to incremental spending in the assisted areas. It's true with respect to health care versus other broad areas, and of course it's true with respect to areas within health care. If you support primary health care to a greater degree, then those allocating resources are likely to move resources from primary health care to other health care priorities. What can be done about this? There are a range of techniques. The use of matching grants is one example. Careful monitoring programs is another example. But in general, it takes hard-headed economic reasoning about incentives to think through the effects of various kinds of assistance measures. And I hope that, too, can be a productive area of contribution between those with a focus on economic analysis and those with a more medical focus. A fourth area where it seems to me there are potentially valuable synergies is at a more micro level with respect to the design of institutions. It's been observed in the United States that if physicians are reimbursed for performing procedures, but gastroenterological procedures, but not compensated for counseling people on how to change their diets to lose weight, they will perform more procedures and do less counseling of people on how they should lose weight. That may be quite unwise if, as the old adage has it, a little prevention is worth a lot of cure. It may well be desirable to develop antibiotics on a standby basis, not for use, but to stand by in case existing antibiotics generate excessive resistance. But the company that does that will not have very much revenue, and in the event that their drug becomes essential to humanity, they are very unlikely to be able to charge a price that will reflect its true value. Again, one has to think about the structure of incentives to design appropriate programs. I think in these four areas, the design of incentives, pondering the best ways to develop assistance and to present assistance, allocating resources among competing priorities where they are inherently scarce, and demonstrating high returns to investment in a world where health resources compete, that economic analysis can make an enormous contribution. I also think that it is essential that we take a multifaceted approach to this, that we recognize the continuing substantial burden of infectious disease in many parts of the world, even as we celebrate the end of infectious disease or the near end of infectious disease in many other parts of the world, and recognize that the issues of chronic non-communicable disease that have long been important in the United States or in Europe are increasingly becoming important in many emerging markets. There is much to think through, and that's why I'm so grateful that your important symposium is taking place. Thank you for the chance to be included.